This is Erica Galvez, CEO of Manifest MedEx. Thank you for joining us for what I am looking forward to is a very robust conversation today about ADT notifications. And if you're joining us from somewhere in California experiencing the bizarre weather patterns, my heart goes out to you. I hope everybody's in a safe and comfortable place today. We are here today to have a fun and exciting conversation about ADT notifications. I think of these as tiny little snippets of information that have massive potential to impact outcomes and quality. And we're going to dive deep with a handful of my colleagues into how they're using those ADT notifications to really achieve awesome things for their patients and their members. I mentioned this earlier, but in case you missed it, Erica Galvez, CEO of Manifest MedEx, and I'll moderate the conversation today. I am joined by a really distinguished group of fellow colleagues, including Gavin, who is the California Market President for Aledade, Jannette, who is a Transitions of Care Coordinator for Central Neighborhood Health Foundation, Dr. John Yao and Tai Huang, who also join us from Anthem, and we'll talk a little bit about how the health plan is using ADT notifications to improve outcomes and quality. Items to note before we dig in: all of your lines are muted. We do that so that we can avoid background noise and the kind of disruption that occurs from that. Feel free to submit questions throughout the conversation as they occur to you. You can do that through the little Q&A box at the bottom of your screen. And finally, want to note for everyone that we are recording this session today. We will be posting that publicly on the Manifest MedEx website and encourage everyone to share that through social media. If for any reason you don't want to be recorded, I cannot see you as a participant, but just know that this will be publicly available. So a little bit of background about Manifest MedEx, and I want to give a little bit of policy context for the conversation today before we dig into some of these impact stories. Manifest MedEx, as many of you may know, is the largest nonprofit health data network in the state of California. Manifest MedEx was created, some people don't know this, so I want to mention it. We were created by a group of health plans and providers who felt that we could and should do better at ensuring that every Californian has a complete longitudinal health record to inform their care, regardless of what plan insures them and regardless of what provider they seek care with. That means our mission and our reason for existence really is solely to ensure that every healthcare organization in the state, and when I say healthcare organization, I mean a broad range of stakeholders, have the information that they need to enhance health, including health equity, improve care, and lower the overall costs across our healthcare system. To that end, you'll see on the slide, we support a broad range of health plans, hospitals, providers, counties, and we do that across the entire state with a set of real-time data services and longitudinal health record services. One of those foundational pillars of the MX service and platform is ADT notifications. And so let me tell you a little bit. I think many folks know what ADT notifications are at this point, but I want to kind of level set with everyone. So on the next slide, I think we've got kind of a high-level summary. These are essentially narrow slices. An ADT notification is a narrow slice of information that gets proactively pushed to care teams when a person they're responsible for has an interaction with a hospital. Could be the emergency department, could be the inpatient setting. But I want to note for everybody, an ADT notification is not a full medical record. It's not a complete health record. It's this slice of information that tells the care team really core things like when their member or patient, where and why their member or patient is at the hospital. And that narrow slice of information is what enables a care team to take action. It's also, I can't emphasize enough the importance of the proactive push, and some of my colleagues may talk about this. Care teams don't have to query for this information and look it up. An ADT notification is something that proactively flows to them to say, hey, you probably don't know that your patient is in the hospital, but they are. And the actions that that notification prompts can be broad ranging. Sometimes those are things like post-discharge follow-up, connecting with the patient when they're discharged from the hospital to make sure that their medications are reconciled, that they have the care and support they need to heal safely at home. Some of the interventions we see based on ADT notifications are also interventions while a person is still in the hospital. We have organizations that actually conduct outreach while a person is still hospitalized to, coordinate care with the hospitalists and the other care teams providing support to that person in the inpatient setting. Whatever the intervention looks like, we have very clear and consistent evidence that ADT notifications improve clinical outcomes, ultimately improve the quality of life for the people who are cared for based on those notifications, and reduce the overall cost for our healthcare system by reducing things like avoidable readmissions. So lots of potential power and value in what is a fairly simple setup from a technology perspective. Now, the CMS condition of participation, many of you are probably familiar with, requires hospitals to share ADT notifications with community providers. That's been in place for about 2 years now. And while it has, I think, without question, expanded access to ADT notifications across provider communities, it kind of creates a messy ecosystem when you don't have a broker sitting between the hospital and the recipients of the ADT notifications to manage those ADTs, match those against patient panels or eligibility files, subscription files, and then appropriately deliver the notifications to the key participants. I'll also note that the CMS condition of participation leaves out a broad range of key stakeholders that are critical in the state of California for what are some very ambitious policy efforts. They don't require notifications to go to health plans, for example. They don't require notifications to go to community supports and other social service providers. That as we lean into a more holistic space around community care, become really important on the ADT notification front. So I'll close out the context by reminding folks about 2 big policy pushes that are potentially massively transformational for Californians in the state of California today. The first is CalAIM. Again, many of you are probably familiar with this. This is a Medi-Cal program that is an ambitious effort to improve prevention and quality and address social drivers of health, focuses on integration of behavioral health, and ultimately managing population health for over 15 million Californians. Folks, that's over 1/3 of the state's population. This is massive. And it depends on data exchange. I would argue it probably depends on a broader set of data exchange than just ADT notifications, but ADT notifications become a really central and critical underpinning for the CalAIM initiative. And then the second that I'll note is AB 133 and the state's data exchange framework and the push by the state to ensure that most healthcare providers and plans are sharing real-time data by January 2024. And that current policy structure has proposed requiring hospitals to share ADTs with at least one qualified HIO designated by the state as a way to ensure that there's a broad ecosystem. There's almost a digital health data safety net, if you will, to ensure that those notifications go where they're needed. So with that backdrop and with that kind of in the back of our minds, let's kick us off with the really juicy stuff. And I'll hand it over to Gavin White from Aledade to get us started kind of in this journey, particularly around value-based care and how Aledade is using ADT notifications. So Gavin, please fill us in.
Thank you so much, Erica. I was, I was quite moved by, pieces of what you were just saying, as we move towards CalAIM and the bill that you were referring to, avoiding that tragedy of the commons, which was on the previous diagram where everyone's just hustling for whatever data they can get, and where the big players win out, the small players, when we're talking about mom and pop shop, independent practices, small community health centers, they're the ones that are going to lose out. And of course, it's the patient that really loses out. and in the clinical outcomes, in their quality of life, and in the total cost of care, which we see ballooning all the time. So 100% agree that coordination here is key and critical. It's hard to believe that 5 to 10 kilobytes can have such a big impact. But I wanted to tell you a little bit about Aledade and what we're doing with ADT and with Manifest MedEx. So let's go to the next slide. So Aledade, or in California, CalEDADE, as we like to call it affectionately, our mission is to enable independent primary care and community health centers, FQHCs, via shifting towards a value-based care. And typically we do that through forming accountable care organizations in MSSP Medicare, commercial, etc. And since launching in California in 2020, of course, Aledade's been around for like 7 or 8 years, but only since 2020 have we been in California. There has been a massive surge of enthusiasm right across the board for these kinds of enablement services. And so we've grown from just a handful of practices in 2020 to the numbers that you see there, managing over $3.25 billion in medical spend, over 6 ACOs. And value-based care really prescribes to us that it's our job to wrap our arms around our patients. It's our job to, have the longest arc of a life and the smoothest arc. We think of it like an arrow shooting through the sky, beautifully creating an arc of a life. And so being able to wrap our arms around our patients requires information, of course. And as an enabling organization partnering with all of those dots you see all over the state, we have to be able to add value, not just in coaching or practice transformation or workflow, but there has to be something behind that. And our Aledade app utilizes data from hundreds and hundreds of sources. And one of these is from, ADT. And, as both a value-based care organization, but also a public benefit corporation, it is our fiduciary and clinical duty to utilize these tools. And so we utilize many ADT vendors and to provide information such as the discharge disposition that Erica was talking about before, all too critical. Someone was discharged to their home. It doesn't have to be that, but I'm just giving an example that we then parse that data, that 5 to 10 kilobits, into our own app, we call the Aledade app, which allows the clinicians to see, bingo, a patient has visited the ER or has been discharged from a hospital to their home, and they therefore require follow-up. Because what we're trying to do is avoid, readmissions or going back to the ED unnecessarily. We're all for using hospitals. We're just not all for using them unnecessarily. And I don't think I have to sell this audience on the volume of unnecessary healthcare that's going on. So let's move to the next slide and we'll take a double click and move in a little more closely. So as I mentioned, we use a range of ADT HIE providers. Manifest MedEx is one of our main providers. We cover about 68% of the state, and which sounds impressive, but when you work in this field, you think, where's that 32%? Well, it's interesting that 32% is worth double clicking on, because 14% of the 32% are with hospitals for which we have no connection and we don't have a partner with a connection. So there is so much work yet to be done. This is really just feels like the beginning of something good. And then interestingly, 17% of coverage are from hospitals where we do have a connection. So there is much work to be done. And Erica and I, and Erica's team and I meet regularly, chipping away at that 17%. And it is, one of those exponential curves where every inch is hard won and fought, with those facilities. So there is a lot of work to be done. But almost 70% coverage is a great start. And obviously it's in areas where we want to see that coverage. And the dots you see on the right there are the practices that we have that are affected and impacted by Manifest MedEx directly. There's 35 practices, which is about 20% of our practices and lives. And that's almost 60,000 lives that Manifest is impacting directly, which impacts directly about $780 million worth of medical spend. That's a lot of, medical spend to work with, and it gives us a lot to play with in terms of, the 92 facility connections that we have with the MedEx team. So then double clicking even further down, well, what does that mean? Well, it means in practice behind the scenes that we get hundreds of thousands of messages from Manifest. Fortunately, I don't have to read them, but there are literally hundreds of thousands that come from Manifest MedEx and from our other providers. We parse those, we dedupe them, we clean them up, as does Manifest as well, and then we parse them into our app and then present one of our practices and the various staff with opportunities for intervention. So now it's a workflow. A minute ago, it was just a piece of 5 kilobytes worth of data. Now it's a workflow. They use the app every day. So they're in the app and they see, oh, hi, Erica Galvez just was discharged from the hospital to their home. Boom, that's now we've got a clock ticking. You've got 7 days to contact them, or 14 days, depending on the TCM that we wanted. And then we have a clock ticking down for them. This is very, very important. It's important because, we want to prevent those readmissions, and we know what is most likely to create a readmission. But it's important in terms of the revenue, the fee-for-service revenue on the TCM is very high. And the CMS, for example, pays extremely well for following up. Why? Because they know that following up prevents readmissions. They support this work. And so Manifest in 2022 was responsible, that hundreds of thousands of pings of data was responsible for around 2,000 TCM visit follow-ups and around 2,400 ED follow-up visits just in 1 year. And when at Aledade, we like to think that for TCMs, for that transfer of care, about 1 in 7 prevents a hospitalization. And a hospitalization you can think of as ballpark $15,000. So divide that 2,000 by 7 and multiply it out by 15,000, and you've got a lot of impact on the bottom line. And of course, 2,000 people, many of those, if we're preventing 1 in 7, just divided in 7, that's how many people we prevented having to go back to hospital again. So their quality of life and their clinical outcomes far better. So let's move on to the next slide. So I've de-identified these names on the right to protect the innocent, but what you're seeing here is a range of practices, real practices at Aledade. And in 2020, when we launched, they were at varying degrees of TCM work, transitional care management. And as you can see, it ranged from, a third all the way down to we don't do it. And this is not uncommon, and there's no critique of those practices. A lot of them simply don't get notified. And so what happened over the 3 years of working with Manifest MedEx and other providers is we've seen a dramatic uptick, as you can see, in those providers. It's dramatic, going from 0 to 40%, going from 30 to 70. I mean, doubling the amount of work that you're doing in there. And so those red highlights, I'm going to double click on in a second, but we're seeing TCM improvements right across as the data improves, as our connectivity to Manifest improves, as Manifest brings on more of those facilities improves. Every time something improves, these numbers go up. Back to that, lots of work to do. So let's double click on these 2 red guys and go to the next slide. Real cases, real TCMs and real data. These are normalized to be risk-adjusted reads per 1,000, just so that we can line them up, and so you can read this appropriately. But you're seeing in practice RV almost a 21% decrease. Now, I know I'm preaching to the choir here, so I won't go into details, but anyone who gets a report anytime that says my hospitalizations went down 20%, 21%, they're cheering. They're happy for their patients. They're happy for their total cost of care. They're happy for everything. There's nothing they're not happy about. That is exceptional. And the 29, a 30. So we're seeing a 20 and a 30% decrease. And of course, you know, your numbers, your mileage may vary. It's not always going to be that. And these were not the only ones on that previous list either, but these were two really interesting cases. Now, when I don't normalize it and don't risk adjust it, if I take just raw numbers, with RV, that practice on the left, you're talking about a decrease in 360 admissions, which is a saving of approximately $5.5 million. Just that left side, one practice. Remember, we deal with about 200 practices right now and growing. So one of that practices, 3 years work, $5.5 million. Boom, like, and that 360 lives, 360 admissions. GC on the right, 29, they got that 30% increase, much smaller numbers. It's normalized here per 1,000, but 23 admissions reduced, savings of approximately $345,000. So I wanted to turn that into real lives and real numbers as opposed to just normalized and percentages. So you had both. Because it's easy just to make it look good on a percentage, but it is really meaningful to the lives, the people who did not get readmitted, and of course the savings to the ACO as well. Last slide, let's go to the next one and look at ED recurrence per 1,000. Again, this is normalized per 1,000, but you're seeing a 26% decrease in ED recurrence, of going back to the ED, of being a frequent flyer, of needing for that. Instead, they're going to their PCP, or they're going to, you know, the right specialist that they need. They're not going to the ED, but, you know, 15 and a half, like a 16 and a 26% increase because of that ADT data allowed us to utilize it. It allows us to turn it into a workflow, and it allows that workflow to turn it into, to transition someone from, I'm repeatedly going to a hospital, I'm repeatedly, you know, deteriorating in my situation, to, we've got our arms around you. You're looking good. And so, you know, we see this right across all of our ACOs, and I can only hope that, and I know we will because we work on this aggressively, improve these numbers and improve the data that's coming through to us. But Erica's right and the team is right when they say small but mighty. These discharge dispositions, tiny little thing, huge impact. Thanks, Erica.
Gavin, thank you for that. It is so inspiring and compelling when you start to really do the math on this and plot out the numbers and think about the impact to real human lives. So thank you for sharing that with us. I have a quick question for you before we transition to Jannette. I'm just curious. Yeah. You know, we have been talking and thinking a lot about this concept of a digital health data safety net, and starting with kind of a core infrastructure for the state where hospitals would send their ADTs to an organization that then is networked with other intermediaries to ensure that notifications get to any provider who needs it, or any support service like Aledade that needs it. And I'm curious for your thoughts and reactions to that, recognizing you're in the trenches with us trying to get this done.
Yeah, I have two immediate thoughts, and some of you may hear in my voice that I'm Australian. Although I haven't lived there a long time. So when you say words like safety net and, you know, universal care, my heart just leaps out of my chest. Because, you know, coming from a country with, you know, universal coverage. But so I'm a big, you know, anything that creates safety nets like that, I think I'm a huge supporter of. I would be definitely interested to see how hospitals respond to the need, the urgency, and the requirement that they participate in these things. I know that the difference between hospitals' responses across the state has been dramatic to some of the new legislation that's come in. Some have absolutely welcomed it. I partner with a number of hospitals in our ACOs, and they have welcomed this with open arms and are incredible partners. I also talk to other facilities that don't want to know. And that the range is enormous in response. And I think the ones that don't want to know feel threatened by, you know, what's coming and what might be required. And but that doesn't mean we don't want to partner with them, and we don't want to be good faith partners with all of the facilities. So I'd be fascinated as to how we can work together to create a safety net like that, because I think that would make a huge difference.
I agree. I think if we all focus on the patient, put the patient at the center, and the best outcomes for the patient, it changes the dynamic of the conversation. Well, thank you, Gavin. Thank you for that. I'm going to keep us going with Jannette, who is going to talk a little bit about the FQHC perspective and how Central Neighborhood Health Foundation has been using ADT notifications to make a big impact. Jannette, go ahead.
Thank you, Erica. Wow, what a pleasure, what an honor to be here today. I mean, to share this panel with such amazing people. Thank you so much, MedEx, for choosing our foundation. So I'm excited to, first of all, introduce myself. My name is Jannette Ruse. I am the Transition of Care Coordinator for Central Neighborhood Health Foundation. I am located in Upland, California. And if we can go on to the next slide, because I am excited to share what our mission is. Central Neighborhood Health Foundation is here to serve our communities. We believe that each clinic, each location positions a part of God's divine plan for our patients. We are such people person at Central Neighborhood Health Foundation. Our hearts are with every single patient. We care for our patients like if they were our family members. This is what I tell when I train people. Whenever you're dealing with a patient, whenever anybody is discharged from the hospital, you need to look at them as they were your aunt, your uncle, your mom, your dad, anybody that's close to you, because you're going to care for them like you would want them to be cared for as well. So this is what we stand for. This is what our organization stands for. And I feel really blessed to be part of this. So let's go ahead and go to the next slide. So our department goals. Now, just to share a little bit about TCM and Central Neighborhood. It's been an amazing, also very tough journey. When I came on board, I've been with Central Neighborhood for since 2021, and there was no actual TCM before. And when I came on board, since it was so new, it was like, okay, this is what it's about, run with it. And luckily, I'm a person that I'm like, okay, let me do my research. What is TCM all about? And I started coming up with personal goals. And then I shared it with my department at the time, and we've been growing ever since. I love to see that now the department's getting bigger. So our goal number one is to obtain daily data from Manifest MedEx, which is a lifesaver, by the way, because honestly, if it wasn't that we're able to get discharge reports, labs, radiology reports, everything in one place, it would probably take me one day to complete one patient, right? But we're able to get everything in one location. So we get reports for discharge. We get, like I mentioned, radiology, which is definitely important when somebody goes for a fractured foot or whatever the case may be, right? And then also 2 labs. That is so essential. And I say this why it's so essential, because the providers cannot do their job if myself as TCM pretty much doesn't obtain all the records that the provider needs. What we want to do is the major goal between these 2 that you see right here is this, that when the patient gets to the clinic, the provider has everything that they need. And I believe till this very moment, MedEx has done that for us. And they provide everything. And I love the communication that we have, that whenever there's something that I don't see on there, I'm able to communicate with the administration team, and they communicate very well, and I appreciate that. So the goal number 2 is provide increased monitoring to our frequent flyers. When I first started, to share a little bit of a story here, it was interesting to see how many ED patients we had. I was like, didn't I just add them to my spreadsheet? I was like, weren't they just there? I mean, refills, things, a headache, very small things. And keep in mind, 2021 was still very COVID, right? Everything was COVID at the time. So I was like, wait a minute, no. Let us take care of you. So I would actually ask the patients for feedback. Why are you going so much? What's going on? What are we doing wrong as a clinic, as a foundation, that's pushing you to go to the ED when you don't want to go there right now? You don't want to spend 6, 8 hours, 12 hours for a refill, for a headache, or something that we can take care of at the clinic. So I started making my list of frequent flyers, and I started paying attention to them more. I started having that one-on-one with them, and I even would give them my direct line on my work cell phone. I'm like, look, call me. They're like, oh, I can't get through, or whatever reason that they would give, right? I said, no, I'm here to help you. I don't want you to go through that process of going to the hospital. The hospital, yes, in some cases, by all means, please go. But for refills, yeah, we want to avoid that. And it's not just, and it's just for our patients and obviously for the foundation that I work for. I take care of both. That's the way I see my job. I take care of our patients and I take care of my foundation. So by contacting our patients within 1 day of discharge is essential. Now, the golden rule is between 7 to 14 days, right? Well, we have a golden rule here at Central Neighborhood. We say within 1 or 2 business days. And the reason is this: there's a higher risk for them to return to the hospital within 1 or 2 days. So we want to avoid that. We want to follow up. We want to say, hey, how are you doing? How's everything? Not just, hey, I need to make an appointment because you need to follow up with the provider. No, it's about having that one-on-one with the patient, showing that you actually care. I think there's a lot of heart in TCM. And I'm going to be very honest with you. I didn't even know what TCM was till I came into the department. And it really touches home. And I'll share that at the end in a little bit, where it's just really understanding why the patient goes. And a lot of the times I've seen they go for reasons that are unnecessary, but we can provide the care that they need here at the clinic. So scheduling patient appointments with their primary doctor is essential because we want to continue with the care. We want to provide them with the care that they need, and we want to make sure that the provider has all the documentation that is required for the visit. So providing patient education is essential. I cannot emphasize that enough. For all my TCM personnel out there, educate our patients. That will make such a difference, and you will see your ED visits be reduced drastically. I've seen that from 2021 to 2022, and I'm seeing it now even more in 2023, and we're barely in our first quarter. The reason why that's so important, because a lot of our patients don't know. And if we don't take the time to explain to them, we know that when they go to the clinic, they go for one thing. Providers have to see other patients. Unlike us, we can take that extra time to educate them, to make them understand the difference of when to go, when not to go, and give them information. It's like I said, it's not just calling them and scheduling that appointment. Go ahead and go to the next slide. So here are our numbers. What I really want to emphasize is the transition of care 2021 versus 2022. So what you see the numbers here is our actual contacting with patients that have been discharged. So in 2021, like I said, I came in maybe like middle of the year. And so there wasn't a department, there was like random people that were calling, and they were starting to develop this department. So you can see that the numbers are low. Now in 2022, I also took over LA. I used to only take care of Inland Empire, but now I also take care of LA. And as you can see, the numbers went up. And that makes such a difference because now we see the reduction in high-risk patients. There's such an importance to watch them. And of course, high risk also equals, frequent flyers, but in some cases it's not. It's just that their condition, their diagnosis is, a little bit more severe, that they do need to go a little bit often. However, also communicating with them, making sure that they follow up with their specialists, like Gavin had mentioned, is, not only with us, but their specialists. That is so important because they have an ongoing treatment going and they feel that they're receiving that care that they need. Go ahead and go to the next slide. So the next steps for transition of care management. So here's a little bit more of a background about us. So this department is fairly new, started 2021, and I was kind of like a one-woman show. And keep in mind, it was new to me. I did all my research. I watched all the YouTube videos you can think of. I asked questions. I know MedEx was a great help with Sarita, Beverly. I appreciate them so much. They do so much for our foundation. And now we're growing. So now we have another TCM member and I get to share my baby with somebody else. And the reason why I say that, and my supervisor laughs with me, because I see it as my baby. Because like I said, that can be my mom, my dad, my aunt, my uncle. It can be a family member, and that I would want them to be taken care of. And one of the scary things about not being on top of your department in TCM is that when we're not watching those little gaps, if we're not really paying attention to the reports, if we're not doing our due diligence for each patient, literally taking our time with each patient, things fall through the crack. And I don't know about you, but I don't want to be responsible for that. If anything, I want to be able to be the solution and not the problem. So as part of that, the department's growing, and not only that, but we at TCM and our QA department merged together. So now I get to work with an amazing team. And I'm really excited because I get to learn from them. They're learning my department, or our department now. And we're working great. And I know we're going to achieve even more excellence in Central Neighborhood. So that's pretty much it on my end.
Jannette, thank you so much for sharing that perspective. It's also so inspiring, the work that you're doing. I have one quick question. I'm wondering if you can give us a story, maybe in like 2 minutes, so we can keep the webinar going. But I'd love to hear any quick patient stories about impact of ADT notifications that you might have, given you are in the trenches on the front line of this process.
So here's one that whenever I've been asked that, this is the one that touches my heart. Now, one of the things I'm a big believer is to be transparent. So I'm going to be very transparent to, it looks like everybody that's online right now. So when I first started, like I mentioned before, I was like, TCM, what's the essence of TCM? And I was at one of the clinics and I received a notification, and I seen that that patient had gone to the hospital within that month 7 times. I was like, this is not normal. I'm like, what's going on? Thanks to MedEx and getting those notifications, I started backdating all the reports, like I think within 6 months, if I'm not mistaken. So even before I started, okay? And I was looking through the reports, and sure enough, there was something that was missed because the patient kept going for abdomen pain. Now you're thinking, okay, abdomen pain, how about a CT, an MRI, at least an ultrasound, something. And I'm like, what is going on? So I go in there, and the last report that I received, the last discharge report, stated that the patient had cirrhosis to the liver. And that impacted me because, sorry, it's just, my mother passed away from cirrhosis to the liver. And yesterday was, yesterday was a 2-year anniversary. So my mother went through the same thing where she was misdiagnosed. So she was already at stage 4. So this patient really, really kind of like took me to that other level. And thankfully I had just started with Central Neighborhood. So it pushed me to give it my all. And so I went, and I was at the clinic. I went to the provider, said, look, this is what's going on, blah, 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 blah. The provider was like, okay, look, I'm going to still see the patient. I scheduled the patient. I spoke to the patient. The patient was crying, confused, didn't know what was going on, which, if you know cirrhosis to the liver, you know, it alters your system, your nerve system, your emotions, because toxins flow through the bloodstream. And so I was able to calm the patient down. The provider was on it, got her the specialist, and the patient is thriving, okay? This patient, who knows what the outcome would have been, but it was a team effort. It was getting those notifications. It's the ADT that we're talking about right now, is being on it. And sometimes we have to go through things like that to be able to be like, wow, no, I need to be good. I need to be great at what I do, because we're dealing with people's lives.
Thank you for sharing that. That is so touching, and what a powerful impact that you've had using data and using your heart and your care and your skill. Thank you so much for sharing that.
Thank you.
Okay, to round us out, I will transition over to Dr. Yao and Tai to give us some perspective from a health plan, and how the health plan is using ADT these tiny ADT notifications to have big impact.
It's a pleasure to be here with everyone. I'm Chief Medical Officer of Anthem Blue Cross of California. And I think, Gavin and Jannette have really done a nice job of summarizing and highlighting the utilities and impact of ADT data, right? I think from the payer's perspective, and I'll just say a few words, and I really want to turn it over to Tai Huang, who is here with me today, and to really share from the payer's perspective, right, and present some use cases to share with everyone. But just very briefly at a high level, from the payer's perspective, what is exciting about ADT data? By the way, I want to also start by saying that our partnership with Manifest MedEx, Erica and others have been great. It's been such a great partnership working with them. And it has just been a joy, So with that said, from the payer's perspective, clearly what is exciting us is that it's one of those, I wouldn't say rare, but certainly not common, circumstances or scenarios where, in my opinion, patients' interest, providers' interest, provider groups' interest, hospitals' interest, and payers' interest are all aligned when it comes to ADT, right? And we may all have slightly different starting points, but the interest is all aligned, right? Because our members, our patients, they don't want to go to the ER unnecessarily. And as Jannette was saying, be there for 8 or 12 hours or something that really doesn't require going to the ER, right? And similarly, I don't know of anyone that willingly, wants to go into the hospital, right? So I think, the data that Gavin and Jannette have shared with us clearly illustrated the impact of ADT, right? But the interest is so aligned across all spectrum, right? The entire spectrum. And that's what's really exciting from, our perspective, right? Because it's not one of the situations where payers may be at odds with providers or vice versa. And in this case, truly, everyone is aligned and we all work together. And ultimately, it benefits, our members and our patients, right? And that's really the bottom line, as Jannette was talking about. So, I don't want to really reiterate anything, right? I mean, suffice to say that we found that ADT data has really been helpful for us when it comes to, inpatient as well as emergency room, right? Management and care coordination, right? It can help us identify patients that admitted or discharged, and frequently the so-called frequent flyers that Jannette referred to, right? Or members that have complex medical conditions that facilitate, improves our communication, right, between our care teams, and it really helps us to coordinate, care transitions, right? That goes without saying, and just as importantly, it allows from the health plan perspective in terms of, our trending and monitoring of data that we're able to monitor and manage the patient flow, right? And those are all the advantages that, I think Gavin and Jannette have alluded to as well. And so I don't want to really dwell on those. And so at this point, I'll just turn it over to Tai Huang, who is here with us today, and he can share a lot more insight in terms of what he's going to share and present with everyone.
Thank you, Dr. Yao. My name is Tai Huang. I am the Director of Healthcare Management. Essentially, I have oversight of the clinical operation for the California local commercial business. So if you can go to the next slide, please. So this is basically a summarization of what Dr. Yao kind of touched on already, members in the middle and all the different care coordination benefits to the from ADT. So next slide, I'm going to talk about a few use cases that we have used for under my team. So the first one, this is one of we all touch on this. Jannette, Gavin, we all talk about preventing avoidable readmission. It's a big one, right? A lot of cost, and this is nothing new to the payer. We always have a readmission reduction program of some sort, whereby we have logic that identify members that are likely, our inpatient members that are likely will have a readmission and a case will be created, get our case manager, contact the member. We are typically trying to get to the member while they're still inpatient to develop that report. Where ADT comes in is it's useful, become useful for this effort is ADT will allow us to know when, as soon as the member get discharges, so that our case manager could then contact the member within 24, 40 hours of getting home, so that we can go and provide these post-discharge interventions, as the other has touched on, teaching them patient education, kind of making sure they understand the discharge, their discharge needs, medication reconciliation, just helping with scheduling follow-up visit with the specialist, with the PCP, helping the member with any community resources, etc. to basically prevent that readmission from occurring. And we started using this before 2022, of course. Last year, I had a goal of reducing our readmission rate of 8%, and we were able to meet our goals in 2022. Pivoting to ER redirection. Previously, we also have an ER redirection program whereby we're looking at claims data and trying to engage the member and identify, assess their care gap and understand why they went to the emergency room. But with with ADT, we pivoted to use ADT, which is a lot more real time, 24, 48 hours of the member being at the emergency room. We would then know that they went and had an ER visit. But however, we did not target every single members that came through the ADT, because there's studies out there that say 70% of members that go to the emergency room unlikely will come back to the emergency room. And Jannette mentioned about sitting in the emergency room for 6 hours. Yeah, that could discourage a few folks from wanting to come back to the emergency room, right? So we only target the members that had 2 or more ER visits in the previous 3 months. We believe that to be the sweet spot. So ADT allows us to kind of get to it earlier than claims. What the outcome from that is, members, when we reach out to members in almost near real time, they are more likely to talk to us. They are more likely to engage with us. So we have seen an improvement in engagement rate, 12 to 15% engagement rate after using ADT versus claims data, right? Because if the member is not engaging, we can't then deliver the interventions, similar to everyone's is doing, basically assess what their current care gaps and introduce them to the virtual live health online, helping them with their understanding of the emergency use, and collaborate with Aledade when it's members that happen to be attributed to an ACO provider. Okay. Lastly, on my use case that I thought be nice to bring here is the discharge dates. I know for any other payers on the line, oftentimes hospitals do not call the health plans to notify that they are discharging a member. We do have non-clinical folks that call the hospital every day to say, hey, is this member still inpatient? And having this ADT feed to us that allows us to know, hey, the member's already been discharged, eliminate the need for us to call the hospital. So save time as far as administrative time. So there's improved the efficiency there. It will help us with an accurate count of our daily inpatient census. So our nurse reviewers can focus on those cases that truly need to be reviewed and not looking at cases when the members are been discharged. And with less cases, the nurses have to go through it and improve our turnaround time as well. Which is a benefit to the hospital and to the planned improvement on regulatory compliance. So that's all I have as far as the 3 use cases that I'm going to use under my area.
Ty and Dr. Yao, thank you so much for sharing those use cases and your perspective on ADTs. I'm curious, I know we're focused on ADTs for this discussion today. This prompts me to wonder, is there additional information, if you had your magic wand and you could wave it, that would be useful in supporting these use cases or other critical use cases that you're focused on?
Yeah, I think one thing that would be helpful, but we're doing it internally, right? We're using artificial intelligence to help us, right, from a large health plan's perspective, and that is to have a better predictive model, right? I mean, ADT data is very helpful, right, in terms of giving us near real-time data, and from that we can glean a lot of information and tie it into the use of AI and turn it into more of a predictive modeling. Kind of similar to what Ty was just talking about, right? That we could identify the frequent flyers, but also not just based on the number of visits, right? Certainly that's a strong predictor, right? From the regression or correlation perspective. But when I say regression, I mean regression analysis, right? Statistical regression analysis perspective. But I think, the way that I see it in terms of future potential really is to have it tie into a predictive model that can really help health plans, provider groups, alike, to have a better prediction that, okay, this is likely to be a one-off kind of admission and discharge or ER utilization versus, this member is on a curve or a line graph where it's more likely that they're going to trend towards repeat utilization, tying into social economic factors, right? SDOH, social determinants of health, tying into health disparities, tying in geopolitical, attributes that can help predict, even food desert, right? Food deprivation, all of those things that really, as a composite, really affects the health of our members and patients. So I think the next step that I see, in terms of even creating more impact and utility out of the ADT data is to be able to couple that with AI and really enhance even more features out of it.
But I do want to add that we do have access to Manifest MedEx portal so that our nurse case managers are logged in and accessing the health records for their intervention. Because for the readmission, I would like to see this chart summary that's available as quickly as possible so that our nurse case manager can leverage it while they work with the member. So that would be my one of my asks is this chart summary to be available as soon as the discharge occurred.
That is such a great ask. And if anyone is participating in the webinar from a health system, the more we can do to close notes and close those episodes of care in the EHR so that that discharge summary is available in a timely manner, the better. We need your help, please. We need your collective help with that. Thank you. Thank you for your perspective, both Dr. Yao and Ty. We have about 5 minutes left, and there are a few questions in chat that I thought I might tee up. There's one from Amy that I wanted to make sure we answer. She asks, she wants to confirm that are ADTs only shared from hospitals to participating providers for existing patients of the provider? And if yes, how are existing patients defined or operationalized? And I can share some perspective on how that works in our system. Amy and Gavin and others may have additional perspective given they run technology that sits kind of outside of the MX network. So we take in patient panels. This is part of the value in one of the early slides as I was setting the context for this, of having a health information organization in the middle of that ecosystem. So we take patient panels in from provider organizations, or we can build those for those providers based on an ADT feed. In fact, from their EHR, as patients have visits, we put them onto a panel for that provider. With health plans, it's based on an eligibility file or a subset of the eligibility file. For example, patients or members in the health plan case enrolled in enhanced care management, just by way of example, under CalAIM. And as we take in those ADT feeds from hospitals, We run those up against the panels and the eligibility files or the ECM program list from the providers and the health plans, and we match those. When there's a match, that's what triggers a notification then to go to an ACO or a provider or a health plan, et cetera. And so there's actually really tight controls within our system around who receives notifications and when and how they receive those notifications. And that is driven entirely based on that, that kind of centrally managed panel structure. Those panels and eligibility files get updated at least monthly. By plan, sometimes they get updated daily. We ask organizations to update those no less frequently than monthly. If they want to update them more frequently, they certainly can. And that keeps that panel refreshed in our system as patients decide to change providers or they change insurance coverage, then that gets updated in our system and reflected in those subscriptions as well. Another question, and this may end up being our last question, but I think it might be interesting to round robin really quickly on this one. Any perspective from folks on the significance of ADT notifications for behavioral health providers? I posted a response to this in the chat based on what we've heard from a number of behavioral health departments that participate in our network. But I wonder, Gavin, Jannette, Dr. Yao, Ty, any perspective from you on the importance of ADT notifications for that tranche of the care ecosystem that is focused on behavioral health?
I think that's a huge tie-in, and that's a great question. So I think the applicability is every bit as much, if not more so, for behavioral health community and patients, right? Because we found that a high percentage of our ER visits, for instance, they may present with chest pain, but it may be because the member may have depression or anxiety or stress, right? Substance abuse and other contributing factors. So we actually actively tie in our behavioral health, specialists into that whole discussion. So I think it's absolutely applicable, yes.
Thank you for that. Any other thoughts?
Yes, I agree. And here at Central Neighborhood Health Foundation, we actually have a behavioral health department. So those notifications, those discharge notes are essential. And just like Dr. Zhao said, it goes hand in hand because they go for one thing and it may be part of it. They maybe have a second diagnosis to that. So combining with behavioral health, they're able to get the complete treatment at our clinic. So I agree, definitely essential.
We would agree as well. We incorporate behavioral health services into all of our workflows, and we include behavioral health facility services. This is such a critical piece of the overall health and wellness of the individual. I was going to say particularly in community health centers, but it's not. It's all across every ACO and every age group. It is a huge concern in California.
I agree. Thank you for sharing that perspective. We are at the top of the hour. I see a number of other questions around the utility of ADTs for public health. And Jonathan Henderson, I will try to follow up with you about my request on ED discharge summaries. I want to thank Gavin, Dr. Yao, Jannette, Ty, all of you for joining us today and sharing your stories about impact. It is such a pleasure to work with all of you, and we're so proud of the work that you're doing and just delighted to be a support for the impact you're having. So thank you for joining us today.